I always like it when people clap at the beginning because it sort of saves embarrassment at the end. But I'm here today talking on behalf of Bausch & Lomb, and find the green button. And I just want to review some of the, well, obviously start off with Bausch & Lomb are very happy to be associated with the BCLA and supporting Visionaries Day today. And I just want to sort of go through some of the wonderful products that Bausch & Lomb have got on offer. Obviously, soft lens products you're probably familiar with, the BioTrue Hypergel lens, which mimics the water content of the cornea and resists dehydration, so is very suitable for patients who suffer end-of-day dryness, and the BioTrue multi-purpose solution, which obviously isn't used with the BioTrue one-day lens, but comes from the same sort of concept of being inspired by nature to try and maintain contact lens wearer comfort and improve the experience. And also the Pure Vision 2 range of reusable monthly lenses, silicone hydrogel lenses. Pure Vision 2 lenses all employ high-definition optics and a high decay to maintain corneal oxygenation. In addition to that, we've got some wonderful gas-permeable solutions. My main work is with the gas-permeable lens division, and this year we've launched the Blink software, which liaises with topographers to download topography and to enable you to design your own custom-designed contact lenses, so very useful for keratoconics, irregular corneas. And that's in addition to our standard Maxim and Quantum ranges, which are available as a standard design in varifocal, toric, and single vision format. And one thing that we're very proud of to launch today, which thank you, Sophie, for mentioning it, is the Maxim scleral lens, which is a lens we launched in May, which is a large diameter, 15.4 to 17.5, standard design, but also customizable to meet as many requirements as you're likely to need. And Bausch & Lomb aren't only in contact lenses now. We've got some fantastic products to help with dry eye. There's the Artelac re-wetting drops and also the Therapearl eye mask for treating blepharitis. So Bausch & Lomb, say, not just a contact lens company, we do other things as well. And there's more we need to tell you about. So reviewing what we've launched this year, we've launched the Pure Vision 2 multifocal lens, which is available in a high and a low ad, optimized to give good distance, intermediate and near vision. The BioTrue One Day for presbyopia, which uses the similar sort of design technology, optimizing vision for early and emerged presbyopes, and Maxim Scleral to meet the more technically demanding fits that you might come across. The Maxim Scleral is also available as a toric and a multifocal format. So we think we've got sort of most bases covered on that one. And that's all going to keep it short and sweet because I know we were a little bit later than intended starting back. Thank you.
Now we're going to have two parts to the lecture by Dr. Nicole Kant, and she is the postdoctoral research optometrist, and she has worked at Moorfields for 2.5 years, and sadly she's going back to Australia. And the first part is going to be acanthamoeba. Don't let this conniving bug put your wearers in the naughty cornea, or is it naughty corner? Anyway, later on, the interactive part, we're going to need your help. So over to Nicole.
Thank you very much, Susan, and thank you very much to the BCLA for the invitation to present here today. So that's very good. You're the first person, I think, that's got the naughty corner. I've had to explain it to so many people. Web designer at Moorfields who came up with it, and we needed a hashtag, and we thought it was quite funny at the time, but we didn't realise that most people wouldn't get it. The idea of today's presentation is to give you an overview of acanthamoeba and how we can enjoy healthier contact lens wear for our patients. So what I'm going to be talking about, a little bit about the organism itself, the signs and symptoms, what to look out for, management and outcomes, some of the epidemiology. We've got very interesting results, you know, here in the UK, we are the you know, the leaders in terms of acanthamoeba, unfortunately, but we do know probably the most about it, and I'll be going through, you know, lessons learnt. We have been doing a research project at Moorfields since April 2013, recruiting contact lens wearers who've had acanthamoeba and also control contact lens wearers through the A&E department. And I'll talk to you a little bit about what we're doing there. And then what's happened quite a bit lately in terms of research, the research funding bodies are wanting us to get more involved with patients in terms of them setting what their priorities would be. You might have seen that over the last couple of years, Fight for Sight had the priority setting partnership, and that was very much including patients, clinicians in the same sort of process. So we have done a lot in terms of our patient support and involvement, and I'll give you a brief rundown on what we've been doing. So the organism itself, that is the active form, the trophozoite, which has the little legs on it here. It moves by contractile vacuoles, and the way that it's cultured in the laboratory is to see it's on a non-nutrient agar plate, and they seed it with bacteria, E. coli, and you can actually see little tracks in the E. coli as it runs across the plate eating the E. coli. So it eats bacteria, fungi, it also likes, unfortunately, keratocytes. Now, the tricky thing about acanthamoeba is that when it gets stressed by environment, drugs that we might be using to try to kill it, the immune system, it balls up into these cysts, these double-walled cysts, and you can see here this is the exocyst and the endocyst. They can tell broadly what type of amoeba it is, the species, by the pattern of the endocyst, and it can live in this form for months, sometimes years on end, and then once the environment is right, it comes out and becomes the trophozoite and starts causing damage. So the signs, now you may not be able to see this very well, and that is because it is quite subtle. This is the epitheliopathy here that occurs in many of the cases, although we don't always see them at this point. Sometimes the symptoms can be quite subtle at that point. And it moves on to this perineural infiltrative signs. So what we think occurs is that the trophozoites are attracted to the nerves, and so you get them congregating around the nerves, and you get the inflammatory cells also congregating there. And that's when we believe it becomes very painful because of the association with the nerves. Fairly rapidly, it moves on to this central infiltrate. So this is often what happens is that people will come in and feel like their vision has decreased overnight because it's become quite inflamed over the pupil, and that's the characteristic ground glass type appearance of amoeba. And here is what years ago we thought was the defining sign of acanthamoeba, the ring-shaped infiltrate that occurs later on. We think this is an inflammatory process. And we also see this in cases of severe fungus, Pseudomonas, so it's not necessarily if you saw someone at that point with this that it would be acanthamoeba, but it occurs in quite a proportion of our cases. These two cases here, very red over the sclera and most likely to have scleritis. So before we did our prospective study at Moorfields, we did an audit of the records, and we found notes for around nearly 200 cases, mainly during the years 2000 to 2012. And the majority of these, as we've seen in previous studies, were contact lens wearers, predominantly soft, reflecting the market, but note that the 10% were RGPs. And to diagnose, generally we do a culture where I was talking to you earlier about the acanthamoeba over the plate in the laboratory, and they can see them moving. They can also visualise the cysts under the microscope. We also stain a portion of the tissue that is removed during the culturing process and can look for cysts down the light microscope. Confocal we use at Moorfields, although many centres don't have access to the confocal, and it really needs to be done by a trained observer, and I'll talk a bit more about that later on. And we have around 20% that we diagnose through a clinical course. So it can be very frustrating for patients when they don't have a definitive diagnosis on one of these two techniques. But if they're responding to the medication and their course is following the normal pattern, we have found that their outcomes are similar to people who are diagnosed through the culturing and the histopathology. So we include them in our studies and do believe that that is something that we can rely on. Now at Moorfields, in this audit, 51% were misdiagnosed initially as herpes simplex keratitis, and that's probably that combination of the dendritic type form initially and also the central clouding effect. And this is a problem because if they're diagnosed as herpes simplex, often they will get steroids as the disease progresses, and we believe that steroids can cause excystment from the cyst form into the trophozoite and make the organism make the infection worse. I'll talk a bit more about that later on. So in terms of signs at presentation, in our audit we found 2 in 10 had the epitheliopathy. About 50% had the perineural infiltrates. We also see these sometimes in Pseudomonas and other cases, but they are often present in acanthamoeba. Around 60% had the stromal infiltration when they presented to us. So this is fairly a long way down the course of the disease, and so we are really trying to educate ophthalmologists and opticians, people who might be seeing these cases, to refer them, if they're not sure, into us quickly, or at least be thinking that it possibly could be acanthamoeba. And around 25% had the ring infiltrate. So these are some images of confocal, and on the left here, these are courtesy of Scott Howe, our master confocalist at Moorfields. So these are characteristic cysts. You can see even with this one, the double wall. We don't see that very often, but they're typically larger than these inflammatory cells, but they look quite similar to them, and this is where the confusion can occur. They tend to be larger and brighter than the inflammatory cells, but you can see there it can be quite easy to get them confused. And this case here is even more confusing. This was actually a bacterial, it was culture positive for bacteria, and these are just inflammatory cells, macrophages, neutrophils, but you can see how easily it might be to confuse them. And when Scott looked at, even with experienced users, the sensitivity was only 50% and the specificity 75%. So it is quite difficult to diagnose on the basis of confocal alone, and we usually use it as part of our diagnostic criteria. In terms of management, they don't respond to antibiotics, so we need to use these strong drugs, some of them used as pool cleaners. So the most common one that we use at Moorfields is PHMB, and chlorhexidine is another drug that's in that category. We usually use a dual therapy, so we use PHMB and hexamidine, which is one of the diamidines, just so that we can give them like a double shot. We sometimes do the polyhexanide by itself because the diamidines do tend to elicit a bit more toxicity, but we never use the diamidines by themselves because they've been shown in the laboratory that some species of acanthamoeba are resistant towards them. There are some potential new therapies on the way, and we are eagerly awaiting those. So here I've got therapy is generally effective if the treatment starts within 1 month from the onset. We do have some cases that, despite being on the right treatment do go downhill quite fast, and we think that's associated with more pathogenic organisms. It's pretty intense, the regime, so it's hourly day and night for 2 days, and then going on to hourly for 3 days, and then they reduce that as the condition is improving. As I mentioned, the drug toxicity tends to be common, and so often we will need to reduce the frequency or take them off one type of the drops to decrease that, so that we get some healing of the cornea at the same time. In terms of deteriorating inflammation and pain, we often use topical steroids. We make sure that we've deferred it for 2 weeks so that it doesn't interfere with the acanthamoeba existing, and we've got some level of control of the amoeba before we start the steroids. And we have a rule of continuing for 4 weeks after the steroids have discontinued. So as I said, 50% are misdiagnosed as herpes, and consequently 50% get the topical steroid. The duration of the anti-amoebic is medium of 6 months, but the interquartile range shows that a quarter of people need treatment of more than 10 months, so it's a very chronic condition. Most people, in our audit, 76% of the cases had been administered steroids after diagnosis to control the pain and the inflammation. And there was a recent survey of American ophthalmologists, and around 70% of those used steroid in the management of the cases. Of course, we need to be very vigilant about IOP increases and other signs. Oral steroids are used if the pain and the inflammation is not controlled, and that's around 17% in our audit. And if patients are not responding to the oral steroids or they're having complications, we'll put them on immunosuppressants, usually cyclosporin. These are some nasty pictures, but unfortunately we're seeing these more and more in our clinic. As we're seeing a rise in the number of cases, we're also getting a rise in the severity of the cases. Scleritis is a very painful condition. We will start with oral NSAIDs, but they often need the frequent drops and to be on the steroids, which causes swelling and lots of other systemic complications. We will often give people, when they've got scleritis, an azole like voriconazole or itraconazole, and there's been some evidence in animal studies that stops acanthamoeba from moving into possibly moving into the sclera. So usually if they're at this level of treatment and it's quite severe, they will be taking that. And these are really strong drugs. Some of the patients report, one of them described it as disco lights in their head, so they have visual hallucinations and things like that. So it's important to control the inflammation, because at these stages we believe that the pain is coming from the uncontrolled inflammation, and with the NSAIDs we'll combine it with codeine. I haven't seen this being used since I've been at Moorfields, the retrobulbar alcohol, and I haven't seen enucleation due to pain. I have seen enucleation due to, I can't be bothered with this anymore, it's destroying my life, I'm going to move on. In terms of, we get around 6% that have culture positive bacteria, usually Pseudomonas type infections, and we would tend to manage that by increasing the PHMB or changing to the chlorhexidine in the stronger percentage. There have been a small number of cases that we've used cryotherapy, which is an incredibly painful procedure. Not during the procedure, obviously they've got local anaesthetic, but in the day after it's incredibly painful. Superficial keratectomy to remove some of the disease load can be used as well. And if it's really going downhill fast, keratoplasty, often they'll get small leaks when they've got this amount of inflammation. The important thing that we've learned with keratoplasty is recurrence is common in a week to 3 weeks after they have the transplant, because they take, obviously, like the button here, and there are cysts in the peripheral cornea, and the cysts, when they get this new tissue, seem to go, here we go, it's new food. And we've actually seen on confocal how they move forward into the transplant. And that can be very devastating for people, where they feel like, oh, all of a sudden I can see because I don't have this load of inflammation in front of my eye, but then quickly they go back downhill again. So it's important that we counsel them that there is that risk of recurrence if they have the keratoplasty during the acute phase. Just a note here that the persisting inflammation does not always equate to viable organisms. The acanthamoeba cyst shell actually has been shown to cause inflammation in an animal model. So there may be cysts there that are dying that send off these signals to cause inflammation. These were the outcomes in terms of clinical course, the complication rate, and you'll see there that over 30% of them in our cohort had scleritis. Raised IOP, obviously they're on the steroids. 1 in 10 have perforation, and other surgeries, mainly cataract surgery, because of the load of drops that they use, they often will end up with a white lens. So our reasons for keratoplasty, about half for vision and half for perforation. We've recently published a paper looking at the outcomes with keratoplasty, and if they have keratoplasty in a white quiet eye for visual rehabilitation, it's much more successful. Final VA, a lot of them do quite well. This is the final VA after they've had their keratoplasty or they've been fitted with an RGP, but you see here that like quite a lot of them don't do well as well. So this was in part of the audit, we looked at the steroid use before the diagnosis, and we found that that was associated with a 4 times risk of worse outcome. In terms of disease state, obviously if you have a more progressed disease state, you're going to have a worse outcome, and that's what we found. And also the older people tended to have a worse outcome. In terms of the history of acanthamoeba, so it was first described 40 years ago, and there were only a small number of cases referred to the Centre for Disease Control and Prevention in the US. But then as contact lenses spread further into the market, we saw a sharp rise. That was most probably related to improved awareness as well, and the introduction of diagnostic microbiology. So we've seen over the past 30 years outbreaks, first with the USA related to homemade saline and swimming in contact lenses. And then in the early 90s, I can remember that I was working in the UK during this time. The chlorine disinfection and the use of the tank-fed water were the primary risk factors at that point. In 2006, you'll be aware of the withdrawal of the complete solution because of encystment factors that was largely responsible for the increase in the rate then. And since that time, the CDC has been looking at a multi-state investigation, as they had 2 reported outbreaks, one in New York and one in Georgia. And they found that storing lenses in water and topping off of solution were the risk factors there. So you can see here, this is a bit of a busy slide, but in terms of incidence per 1 million contact lens wearers, you're looking at around 20 for the UK, with a wide range depending upon the environment compared to, so it's 10 times more than what we see in the US. Of course, it is still rare, but the difference points really to the fact that in the UK we have hard water, and when Cherry Radford and John Dart did their studies back in the 1990s, found that there was a great association between where you lived and the hardness of the water, so increasing it a 4 times relative risk if you're in a hard water area. Recently, Charlotte Joslin and Elmer Tu in Chicago have looked at the water purification as a factor. So what they found was that the further away that people lived from the water purification plant, the higher the risk they had of acanthamoeba. And that was probably because with the water they were finding a carcinogen byproduct in the water, so they changed the level of disinfection and were finding that acanthamoeba was building up in biofilm on the pipes. Here in the UK, we looked previously with Simon Kilvington at tap water samples from patients with acanthamoeba, and we found a high level of free-living amoeba in systems, particularly those that have tanks. So in terms of other bacteria and organisms building up in the tanks, then amoeba has a food source and is particularly happy. Simon also looked at, he has quite a neat way to look at the organisms using gene sequencing, and found that there was an association between people's water in their homes and the samples that we were taking from their taps. So implicating it as the source of the infection. So with our study, we're looking at the severity and susceptibility to acanthamoeba depending upon the person's host immune profile and also the organism, doing the wrong button, the organism itself. So in my PhD, I looked at bacterial keratitis and found that some of the interleukins that were implicated in models or animal models of bacterial keratitis, if you had small mutations in some of those genes, you were likely to have a more severe outcome and to be more susceptible to bacterial keratitis. So we believe with acanthamoeba, where there is a very much of an immune component with these stromal rings and scleritis, and a difference in outcomes, so between 3 and sometimes 3 months and 3 years, that we'll find associations with the actual host immune profile. So currently in our study, we have 149 cases enrolled. We're aiming for 160. 120 or so of them have been recruited, patients that have been presented to our clinic between April 2013 and now. And we're currently just concentrating on our control cohort. So we hope to have results of our case control study in about February. So we started off looking at the immune response, and so we're collecting DNA from mouth cells, getting them to do a mouth swab. We're also collecting tears to look at the immune profile in the tears biomarkers. We've collaborated with Simon Kilvington to do looking at water samples as well as the corneal samples, and of course we've been doing the risk factors and looking at quality of life also. What was unexpected was the patient pathway, and that's become a big part of our project. So as I said before, we are seeing this increase in incidence and severity, and it's meant that this risk factor study has become more of a priority for us. So with the water sampling, we started just doing the cold water taps of the kitchen and the bathroom, but we weren't getting much acanthamoeba, and that's most probably because a lot of the taps these days have filters, and so we're not actually getting to the biofilm. So we've now started doing the overflows and the drains, and the overflows are proving particularly fruitful. So we send them a little kit like this through the post, and they sit with a postage paid envelope straight to Simon and with instructions, pictorial instructions, and they send them to him. And we have results in around a month or so. Most people have been really interested in what their tap water is like, so we do tend to give them the results. And these are some of the results that we've got. So these are the free-living amoeba, and so other types of amoeba other than acanthamoeba. And we do tend to get a higher proportion of those. And Simon thinks, well, this is possibly that the environment could sustain acanthamoeba if it was in the system. And these are the acanthamoeba amounts. So as I said, the overflow is particularly good at culturing that. And, I said to him, well, how, in terms of them getting into the overflow, how is that going to be happening? And he said, basically, what he thinks is it's going to be splashing back there and forming other sorts of biofilm and a food source. So he's just looked at a small number. So we've been sending him our corneal isolates from the laboratory here in London, and he's looked at them with this same type of analysis, DNA analysis, and he just took a small sample and he's found quite a bit of association. So we're fairly confident that in most cases the amoeba source is the tap water or the water in the house. This is just a slide that I presented at BCLA early this year. It's looking at the quality of life, the impact of the vision impairment, and I've just graphed here. This was a 5-point scale, and this is the top 3 in terms of it was affecting them a fair amount. And things that surprised me that came out in the questionnaire, I had been talking to the patients about it, but things like reading just normal size print, fear of falling also came out as significant in terms of that study. It does have a big impact upon people. In terms of the patient perspective, there's a horrible video on YouTube, The Animal Planet, which has amoeba crawling through and attacking the brain. And we always say to patients, you probably will go on the internet, but take it all with a pinch of salt. There are some good acanthamoeba information websites. This project, John Dart is the medical advisor on, and they are it's funded by the European government, and he's going to be developing a licensed product, PHMB. They're looking at trying to find what is the most effective concentration of that organism. The CDC in the US also have a nice page. I have been trying to get them to take the parasite out of it. It doesn't sound good, but also acanthamoeba is not technically a parasite because it can live by itself. It doesn't need a host to survive. When patients have the condition, particularly when their vision is down, they have a lot of photophobia because of the distortion of the light. Just a pirate patch has been a saviour for some of them. And even in that short period of time, they start to have problems with their stereopsis, bumping into walls. They report not pouring a drink into a cup properly, not putting their hand out in the right place to get change, and that can really knock people's confidence. This book is a pilot who lost his eye through an accident, and it gives them practical tips for the short-term loss of that stereopsis. One of our patients who's had a particularly severe case of acanthamoeba, Irene Akeshis, lost a job. She had a marketing background, and she, after talking to a lot of patients, was quite surprised that most people weren't aware that water and contact lenses don't mix. So she came up with this concept of a no water symbol, fairly simple idea, and we are very honoured and proud that the BCLA have endorsed that concept and have printed these left and right stickers. There are some on the stand that you can have a look at and take a sample, and we'd be really happy if you purchase some of those so that you can give them to your wearers, put them on the boxes, and give them a visual sign that water and contact lenses don't mix. We've been having patient focus groups, about 3 over the past year, and at the first one of the things that people said was they'd like a patient information leaflet to be given to them at diagnosis that had the information that they wanted, not only in terms of what's going to happen to me, but things that they didn't feel they could ask the consultant, such as, can I wash my hair while I've got the infection? Can I go to the gym? And things like that. And it's got all that sort of thing in it. The other thing that was particularly asked for was the fact that their appearance changed with acanthamoeba, and some support websites for those sorts of things. As a result of this study, and particularly our patient involvement in the study, we've been recognised by the Moorfields Communications Department and also the NIHR Biomedical Research Centre. And recently we had a Healthy Habits campaign, which was run in conjunction with Freshers Week, and we had quite a good response to that. This week it's the CDC's week of healthy contact lenses, and so it would be great if you went onto their website and checked out what they were doing. They were very collaborative with us and shared a lot of their informatics, and they've got a very good team behind getting messages out, particularly to young wearers. So the take-home messages from today is it's rare, but it's a severe condition. And we are seeing that rise in the incidence and the severity, both here in the UK, not only at Moorfields, at other centres in Bristol and Manchester, and in the US. As John Dart says, 90% of these cases can be prevented by avoiding water contact, and we think it's really important that patients know that there is a risk and that they are aware that they might be able to avoid that risk by simple things like drying their hands after they've washed them, not showering in contact lenses, and not swimming in them, and those sorts of things. It's important to include acanthamoeba in a differential diagnosis in contact lens wearers when they have an infection. And from our work in steroids, we're really advocating that it's important that if there's some sort of epitheliopathy or infections that are not resolving, that steroid use is not started unless acanthamoeba has been ruled out. And so in terms of acknowledgements, I'd like to firstly acknowledge the patients and the controls that are in our studies. Our team consists of John Dart, Simon Kilvington, Alison and Virginia. Alison's a geneticist and Virginia's an immunologist at the Institute of Ophthalmology. We've just collaborated with Dr. Tane Clark from the London School of Hygiene and Tropical Medicine, and we're going to be using some of these next generation sequencing to look at the acanthamoeba organisms that Simon's collected over the past 20 years and see if acanthamoeba is changing in the organism is changing in the environment, and that might be why we're getting more severe cases. And Irene, I include now firmly as a part of our team, our research team. I'd like to acknowledge Catherine Chisholm, who got behind the no water stickers at the beginning, and Cheryl Donnelly, who's really taken that on board. So I'd like to give a big thanks to them. And at the Moorfields Biomedical Research Centre have also supported our endeavours and been helping us with doing some videos, which you'll see in the next section. And again, the communications team have been great as well. And as I said, the US Centre for Disease Control, they've shared a lot of their informatics with us, and we consider them a collaborator in our sort of campaign for more healthy contact lens wear and more open discussion with wearers about risks such as water. I think that's it. Thank you.
Now, before we go on to part 2 of this, are there 1 or 2 burning questions you want to ask Nicole about acanthamoeba before part 2, or shall we just...
Of those factors, but we need quite a large control group to see whether there are those sorts of factors. My indication, my gut feeling is no at this point, yeah.
Okay, thanks.
Thanks very much for your presentation. I promised I would ask this question of you because I had this question from a patient of mine who is the parent of a child who wears contact lenses, and she said, well, I take them off for showering and bathing and swimming pools, but what about when I'm out in the rain? And I said, well, I really have no idea, but I will ask if there's been any research into how much acanthamoeba is in rainwater.
I would be not, I don't think I'd be concerned about rain, no.
Because with little ones, it tends to sort of fall down the face.
Yeah, yeah. I think the thing is that we believe it is everywhere in our environment, but it tends to be in proliferating places where there's biofilm and other organisms. So in like the shower heads, there probably is in the UK, and you know, when people are washing their faces and maybe splashing water into their eyes, those sorts of things. But I think rainwater, you couldn't say you're 100% safe, but I wouldn't be concerned. Yeah. Yeah. Okay. My next slide. Yeah. Okay. Sorry. So, as I mentioned, we've been working with the Moorfields Biomedical Research Centre to try to have some tools to be able to talk to practitioners about these risks. And we were really honoured that the BCLA donated a stand to us at the recent clinical conference to talk about healthy contact lens wear and really promote some of these messages. And so you can see there that there's a big screen, and we wanted to have something on our screen. We made these posters, and we had some posters from the CDC and our no water symbol, but we wanted to put something onto the screen to attract people as they were walking past. And so we designed a series of 4 videos of what we call witless wearers. So they're particular characters who are doing the wrong thing with contact lenses, and as a challenge to be able to work out not only how to identify the issues, but also how to communicate with them, with the patients. And when we were designing these scenarios, we looked at it based around the health belief model, and this has been adapted from the medical compliance, and it's a series of thought processes that someone might go through when they're deciding whether they're going to follow your advice. So it says that they need to feel that they're susceptible to getting the infection, that it's going to be severe enough that they're going to want to avoid it, that by changing their behaviour they can prevent it, and that there are not too many barriers to against changing their behaviour. Sorry. So this is one of the videos that we made.
So I'm going to teach you how to find the perfect handbag, because I know how difficult it can be. So this is my kiki bag. Okay, so I live in my bag. I literally have like my whole life in my bag. Check this out. Oh, lavender scented eye mask, hair rollers, contact lens case. Oh, 2 contact lens cases. One of them's probably my old one, but they're handy to have. Nail varnish, hair straighteners, another contact lens case. This is great for putting all those tiny little things in that get lost in the bottom of your bag, you know what I mean? Like the backs of earrings, buttons, all that kind of stuff. Great, gotta have one of those. Clutch handbag, just in case you're going out. My favorite mascara, I've had it for like 2 years. Luna mascara. Sunnies! I love my sunnies!
So we had some messages at the end. We have these on our website, so we had to sort of design them so that they had some of the good messages coming through. So if you, these are on the Biomedical Research Centre YouTube channel. I think that's finished now. All right, on to the next. All right, so Shona is actually a friend of mine, and I've been speaking to her since we made those videos, because I realised that she was actually doing a lot of the stuff that happened in those videos. So I've been talking to her and trying to educate her, and I'm confident with the discussions that we've had that she's turned over a new leaf. So I thought it'd be interesting to invite her along and talk about some of the things that worked for her in terms of the communication styles and things like that. So welcome, Shona. Hi!
So good to be here.
Well, come and take a seat, Shona. Ooh, hold on. Don't trip over those shoes. Let me just get my clicker. Here we go. So tell me, what's been up? What have you been up
Well, besides buying a new handbag,
to? Nice.
I've been visiting online and I came across the most divine pair of jewelry lenses. Do you remember I showed you a picture? I think I texted you one.
Not those.
Those are them, they're so cute. Anyway, so they just made my eyes water and it just smeared my makeup everywhere. Oh. And then you just couldn't see the beautiful crystals through my tears.
Didn't I tell you that was going to happen? What did I text you back? No. N-O.
Well, I probably deleted that one by mistake. But don't worry, because I'm not wearing them anymore.
Phew. So you're wearing those nice daily disposables that I told you about?
Well, no, but I did see that after you told me to throw away the cases, remember? I did see this thing on BuzzFeed. Do you remember about the acanthamoeba?
Acanthamoeba, yes.
That's the one.
Not that. You didn't see that, did you?
Yeah, that's the one. Oh my gosh, and this woman was there. She got this infection. She'd been wearing her contact lenses for like 6 months. So I went, no way, that's not going to happen to me.
Good, good.
So I only wear mine for 5 months at a time. Anyway, but what I have to do is when my boyfriend's not looking, I just run them under the water because they get so dry. Oh my God.
What did I tell you? I told you about that lady with the no water stickers that had acanthamoeba for over 3 years. I told you about
I know,
her.
I remember. I even brought the little labels with me. Look, they're so cute. Do you know what I do with these? When I go to aerobics, because like I don't remember my left from my right, so like I put it on like my left hand, and then I put the R one on my right hand, like that. And then when the aerobics instructor says go left, go right, I can just check it out and then, you know, do it.
My goodness.
Anyway, you're always telling me to be careful about this and be careful about that, and like wear your seatbelt and blah, 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 blah. You're Australians and your nanny state. I'm just not into all that stuff. But you know what I am into? I made a new video, one of my video diaries. Can I show you?
Yes.
I've just got one thing to say. Last night was like the best night ever. Me and Emma in the club. Oh, amazing. Way better than like space in Ibiza. I mean, check these out. We got these babies. Oh. They're so cool. You can get them anywhere. Oh, those are Emma's. Anyway, after that night, you know, like you said, you know, you've got to chuck out your cases. So anyway, I had to go and get another case, just in case.
Right. Okay, well, it's been Lovely to see you. Obviously, I haven't done very well. So, can you help me with Shona, or is it Bryony? And help me to see where she fell off the ladder, because I obviously thought I had her picked. So if we look at the health belief model in terms of the susceptibility, severity, prevention, and the barriers, can anybody give me an idea of where I should have been targeting her education? Sorry.
So do I have a go? Well, she's non-compliant,
Hey?
isn't she? I am not. She is. Hang on.
As a contact lens wearer, she is susceptible. And it's the severity of the condition. Yes, it's very severe. Does she believe she can prevent it? Yeah. But the reasons aren't there for her, in my mind, to actually follow your chain of thought.
Yeah, yeah. Do you think she thinks that she's susceptible?
To me, I think some of the things that you've said, she's taken on board.
On balance, not much though. Someone who thought that she wasn't, she didn't believe that she was susceptible. Do you want to tell me why? What some of the signs were?
Just a different language between you Australians and I'm not really interested in the problems. I want to live.
Mm-hmm. Yeah, I think that leads nicely onto my next question. What was the problem with me?
Where do we start?
I can't act.
You didn't speak her language.
Mm-hmm.
So you didn't tell her what the risks were? No? Your go.
I guess.
Empathy?
Yeah, I guess. Yeah.
I think the biggest issue was you didn't give her solutions to suit her lifestyle. She made it very clear to you what she wanted to do, and you told her what was the right thing to do, but not what she could do to make her life easier, like having spare lenses, etc., etc.
That's excellent. Yeah, yeah. So what what might have been a strategy that I could have used, like in terms of dispensing lenses, that's particularly topical at the moment? Yeah.
Sorry.
Yeah.
Yeah, I think managing her life. So you give alternative lenses, you have daily disposables for when you go out, you keep a spare pair of lenses in your bag and not a spare case. You know, so you safeguard, you plan for the unexpected. So if you're out, you throw your lenses away, knowing you've got an extra pair of lenses in your handbag for tomorrow. You know, so it's given solutions to match her lifestyle.
Yeah, yeah. Anybody else? Yep. Oh, Cheryl. Are you listening?
Taking it all in, taking it all in.
It's unrealistic expectations from the practitioner. We always say, don't swim whilst wearing contact lenses, don't shower whilst wearing contact lenses, but frequently, if they go down the gym, they're going to be wearing their contact lenses, they're going to shower afterwards. Are they going to take their lenses out beforehand? Should we give them other methods of getting around that? What about using goggles over the top of their contact lenses while swimming? There's dangers of not being able to see when you're swimming anyway. So, alternatively, daily disposables, you finish with them directly after swimming.
Yeah, that's good. That's good. She looks after her appearance quite a bit, and one of her choices. Oh, has been to use coloured contact lenses herself. So one of the things I was thinking, maybe I could have prescribed her some coloured contact lenses and told her how to use them. Very, very quickly, would anybody like to give some quick advice to Shona?
Sort your shoes out. How can you walk in those shoes?
I'm impressed she can walk in them.
I'd just like to make a comment. I think that one of the problems is she's highly non-compliant. In highly non-compliant, she's probably a risk taker. Non-compliant patients are risk takers, identify the things they do in life. So it really is a question at the very beginning to realise these patients are risky to take big risks. And so she'll probably sleep in lenses as well. Given her one-day lenses, he's not really going to comply. She'll still put them in a cup of coffee and get some McDonald's. So I think sometimes with patients like this, you have to frighten them.
Yeah.
To really realise the consequence of her actions, she could actually have severe scarring to her cornea. To turn the screw that little bit more. So it's like driving a car. We all drive cars. We know that under icy conditions, you can't drive at 90 miles an hour. She needs to realise, which she probably doesn't, the consequences of her actions, which most of us don't do. We think too much of a negativism. Don't tell them.
But Jonathan, that journey, that story begins day one when you first fit a patient with contact lenses, because you offer freedom to that patient, but that freedom comes at a price. And to say that the worst thing that can happen is one day I say to you, you can't wear lenses anymore. And I never want that day to come. So here's my part of the job. This is, as a clinician, we have to take ownership and responsibility to do the best for our patients, because I believe there are lots of clinicians who are non-compliant as well about their healthcare to their patients. So we have to do our job and we have to convince our patients to do their jobs. But it starts day one and we keep reinforcing it.
That's excellent, yeah.
Actually, I was going to say something very similar to what Shelley just said, and it's more of a question really, because if you've done everything you can and you've not put the whole scientific approach on it, you've tailored it to their lifestyle, they keep coming back and they keep saying the same things, at what point do you just say, okay, if I don't want you to be my patient anymore, because if anything happens to you, it's gonna reflect badly on me. It's more of a question.
Sorry,
really.
I think we're running out of time now, so we need to press on. I think I'd show them some really gory pictures personally, but shall we all show our appreciation in the normal way? So now we come to the Alcon sponsors presentation, and it's called Alcon Stare Off, but we have a different presenter today, who is Jennifer Devine. She's the Trade and Marketing Manager, and she's been with Alcon for 4 years.
Thank you. Oh. Thank you ever so much. First of all, I'd just like to say thank you ever so much for the invitation to attend BCLA this year. So I'm going to keep it really short and sweet, because I know that I'm the only barrier to the tea break. So we're going to aim to spend about 4 minutes instead of 5, and 3 minutes and 40 seconds is going to be a video, so I won't even be talking. So our vision within Alcon, as you can see, is to be the most trusted leader in eye care. But we're all about innovation. We've had 4 new products in the last 18 months, but I don't want to talk to you about that. This is not a product-focused presentation you'll be pleased to hear. So I'd like to introduce the Stare Off campaign to you.
So, this is my 30 seconds of talking. There's a couple of things you can do to get involved with our campaign. It will be starting next week, so most of you will receive POS packs through the post inviting you to engage. As you saw, there will be £300 worth of high street shopping vouchers up for grabs for the person with the longest stare in the UK. But we've got a new website that's active for Dailies Total One, free trial vouchers for patients, but encouraging you to get involved as well by linking into that website. We've got a practice finder, so please, if you're not on the list, please get in touch with us. Encourage your staff to recognise the free trial vouchers to be coming through. As you've seen, this is a massive digital campaign. It's online, there's billboards across London, it's going to be all over the place. And finally, if you want more information, please come to us. Thank you ever so much.
So we now break for the drinks reception, and we need to be back in this room for 6 o'clock for Professor Dewar, please. It's my great pleasure to introduce the 2014 Pioneers Lecture with Professor Harminder Dewar. Professor Dewar was President of the Royal College of Ophthalmologists for 3 years, and for 7 years he edited the Ophthalmology Journal, and he has just told me that his daughter is studying optometry at Cardiff University. And his lecture is the novel Predecimates Layer, the Dewar's Layer, its discovery, characterization, clinical implications, and surgical applications. And he will take questions at the end of this lecture so that you're well prepared.
Well, thank you very much, Susan, for the introduction, and mostly for your very kind invitation. This is a high honor. I'm privileged to be here and to give the 2014 Pioneers Lecture. The title, as you see, is quite a mouthful, but the story is very interesting, and I do acknowledge the work put in by other members of my team. Having been in the game now for so many years, I begin most of my talks with these 3 lines. Some of you would have heard most of this. Most of you would have heard some of this, but not all of you would have heard all of this. So let's see how it all started. We've had more than 100 years of cornea transplantation, and through all that time, these problems remain. Rejection and failure due to rejection. If the stem cells are involved, you have guaranteed failure. Even if you get a very clear graft, if there's very high astigmatism, you don't see very well, and forever the graft-host junction is weak, and a little trivial trauma, we've had cases 30 years down the line, and the eyes popped open and everything, the vitreous lens comes out. This is a cartoon I picked up as a method of checking cornea grafts. It is crude, but it is effective. And we have been struggling and grappling with these problems through all of these 100 years and more, trying to find solutions. The solution did not come through biology, it came through surgery. And now we have different operations for different indications. When the stroma of the cornea is affected, like in this patient with granular dystrophy, or when you have keratoconus or scars from infections, then we do deep anterior lamellar keratoplasty. So we leave the desmes behind and we do only the stroma transplant, and they never get endothelial rejection or failure thereof. If the endothelium is involved, then we replace only the endothelium in different acronyms, the desmes stripping endothelial keratoplasty, desmes membrane endothelial keratoplasty. And the advantages are that you don't have a graft-host junction and there are no sutures, so the weakness problem is eliminated and the induced astigmatism is no longer there. So big advances, and for some reason in these operations, where we do the endothelial transplant, even the rejection rate is less, and there are theories to explain that. And here's an example where an endothelial graft is in place. This was Descemet's stripping endothelial keratoplasty, as you can see over here in this slit image. And there is no suture except for a little bit where we insert the graft from a couple of stitches. This is hardly 3 millimeter incision. So this is how the story started. So I'd been doing deep anterior lamellar keratoplasty for about 8 or 9 years. And just a very quick video, short video, to show you what this operation is, because that's what everything else hinges on. So what we've done here is we've taken the trifine and we've gone into deep stroma and cut it in a circular manner. We haven't gone through and through. We've marked our suture points with this blue ink. I've taken a 27 gauge needle or a 30 gauge needle, beveled down, filled with air, attached to a syringe filled with air, and a little drop of Helon on the top to magnify the needle tip as it is inserted into the stroma. And then I'm going to inject air, and that's where this video starts. So what you'll see is a big bubble appear in the stroma with a white ring as it spreads to your trifine mark. And this operation was invented by Muhammad Anwar, and it's called the Anwar's big bubble technique. So this big bubble separates the Descemet's membrane with the endothelium from the rest of the stroma. You take away the top half or 2/3 of the stroma, and you're left with this bubble trap between Descemet's membrane and the anterior stroma. Then you puncture the anterior stroma very quickly as the Descemet's bounces up. You want to avoid perforating that, and you can then fill this space with a viscoelastic substance, hyaluronate, or you put a spatula in like that, and then do a bit of tightrope walking as you incise the stroma in 4 quadrants, and then you cut it off. And Muhammad Anwar described this view, the anterior surface of the exposed Descemet's membrane, as one of the most satisfying views for a cornea surgeon. And then you bring on it a cornea from which you have taken away the Descemet's and endothelium and stitch it into place. So that's your deep anterior lamellar keratoplasty. This is the procedure of choice for all keratoconus patients who need a graft, and they have no risk of rejection. While doing this operation, there were certain things that were not adding up. There were certain clues. One of them was that when I look at this exposed Descemet's membrane, it appeared pretty resilient. I could bounce a forceps off it, unlike what you'd expect from a Descemet's membrane. If inadvertently there was a little tear or a nick in this, it wouldn't roll up like a Descemet's membrane. Despite that tear, we could go on and complete the operation. And when we do penetrating keratoplasty, which is full thickness cornea transplantation, we're always taught to take your needle out just anterior to the Descemet's membrane. Don't perforate the Descemet's membrane except in very young children. So here, that's what I'm doing, and you can see the needle emerges in front of Descemet's membrane, showing a beautiful edge, right? So just bear that in mind. Now here is a video showing how the Descemet's is being removed from the donor cornea, which we are going to then put on an eye where we have separated the Descemet's membrane by that big bubble technique. So notice how easily the donor separates. Now this separation is easier the older you get. It is advocated that when you do endothelial transplant using that tissue, you should not try it for anybody less than 50 years old, the donor, because it would tear the Descemet's membrane because it's more firmly attached. Now bear that in mind, and now look at this. Now here I'm suturing that cornea back onto the patient's eye, and I can still see an edge. So I've just removed the Descemet's membrane. Why is there still an edge? If the edge was produced due to the Descemet's membrane. So again, something didn't add up over here. And then in the next video, what you see is that the air bubble hasn't quite gone to the edge of my trifine mark. So I'm now trying to separate the stroma from the Descemet's, and I encountered these strands. And many, many surgeons have encountered such strands, and sometimes they're so tough that they have to be cut out. So the question was that if you separate the Descemet's membrane from the stroma, it peels off so easily. So why is it that when you separate the stroma from the Descemet's membrane, you get strands? Are we working in the same plane? And the answer to the question was probably not. So we hypothesized that there exists a distinct layer in the posterior stroma that is different from the Descemet's membrane, and the plane of cleavage in deep anterior lamellar keratoplasty when we inject air is not between stroma and Descemet's, but rather between this layer, which we call the pre-Descemet's layer, and we then went on to simulate the DALC operation in a number of human eye bank donor eyes to see if we can prove that hypothesis. And early data from this work was presented in the year 2007 in 2 different conferences, one in the UK, one in Italy, and we call this layer the pre-Descemet's stroma layer. But at that time, it was still a hypothesis based on some clinical clues. Now, what we found is when we inject this air, different things happen. Now, here's a sclerocorneal disc which is looking at you under the microscope, and I'm injecting air. And notice what you'll see is air leaks from the periphery, but in the center, this large bubble appears and then spreads centrifugally towards the periphery, and you can wash away all those bubbles to expose and reveal that large bubble inside. Now, this is a central bubble which started in the center, spread peripherally. We called it the type 1 bubble. And here are some examples of this type 1 bubble. Then if you look at the other situation, which happens in about 15 to 20% of times, a large thinner wall bubble appears at the periphery and spreads across the entire surface of the cornea. The previous one was restricted to about 8.5 millimeters diameter. In this eye, you will see another one, again starting at the periphery, some leakage of air, presumed to be from the trabecular meshwork. Another bubble starts at the periphery, and then it merges with the other one, and it's a huge, big one. So a thinner looking wall, starting always at the periphery, spreading across the whole surface of the cornea, as against the other one, starts in the center and does not go beyond 8.5 millimeters. So type 1, and this is the type 2. And here are some examples of the type 2, and here we've used Vision Blue to stain the Descemet's. And then we found this very interesting appearance, which we call the mixed bubbles, where both types, a large central type 1 and a huge horseshoe of a type 2 bubble, and again a large central type 1 and a crescent of the type 2. Now, interestingly, these observations were made by surgeons, including myself, during the DALC operation in patients. We call them funny bubbles. We did not know what was happening, and we thought, as Anwar had first published, that there is a split between the banded and non-banded zones of the Descemet's membrane. The air gets inside, and that's why in some sectors you get one bubble due to separation of Descemet's within its layers, and the other of separation of Descemet's from the stroma, and that's what we all accepted. Occasionally, we found this. It's very rare, but both clinically and in our experiments, we found this, where you get complete 2 bubbles. Here is an inner type 1 bubble and a huge outer type 2 bubble. So you've got a complete type 1 and a complete type 2. Very fascinating to watch. So we moved on. So all right, we got these 3 kinds of bubbles. So what next? So we create a type 1 bubble. Can we peel off the Descemet's membrane from this? If it is truly a bubble behind, or anterior to rather, the plane of the Descemet's, then we should be able to peel off the Descemet's membrane without deflating the bubble. And that's exactly what happened every time. You can completely remove the Descemet's membrane. The layer underneath is totally impervious to air. It will trap air under very high pressure without letting the air through it. As you noticed in the previous corneas, and you'll see in the other ones, as I inject the air, the whole cornea froths up with a lot of tiny bubble, becomes white. And that air spreads to the whole stroma. Well, when it reaches this layer, it peels it off as this bubble, but air does not go through it. So that was quite interesting, that's the reason why this bubble actually separates. So here, the complete Descemet's membrane has been removed, and that layer, impervious to air, remains. The bubble is not deflated. And then we looked at this Descemet's membrane from all the samples, even from the mixed bubbles, which we took out the Descemet's membrane. We did electron microscopy, and here's a transmission electron micrograph. You see the Descemet's membrane here in its entirety. There's a banded zone, the non-banded zone, and the endothelium. In fact, there was never, we have done now 165 eyes experiments, we've never found a split between the banded and non-banded zones of Descemet's membrane. So immediately our understanding of the operation changed, and we know now where the plane of cleavage is and what's happening when we get those funny bubbles. Then the question that we asked was, what happens if you take the Descemet's membrane off a type 2 bubble, and can you create a type 1 bubble after completely peeling off the Descemet's? So here we inject air the other way around. We put the eye in an artificial anterior chamber, we inject from the top, and you can see everything goes white, and underneath we've seen this very large, nice type 2 bubble. So this type 2 bubble, and as I try to peel it, you see it's starting to deflate. And as you take that Descemet's off, this bubble always deflates. So it's telling you the type 2 bubble, which occurs in 15 or 20% of the time, is very different from the other one. It's a totally different plane of cleavage, and exactly what happens in the human eye, as you'll see. So here what I do is take away the Descemet's membrane completely, and in the same eye then go with another needle and inject more air to see if I can create a type 1 bubble without the Descemet's membrane present. So it answers the question, is the Descemet's, or is the presence of the Descemet's membrane imperative for creating a type 1 bubble? And the answer is no, it's not. Every time you can take off the Descemet's membrane, inject air, and create a very nice type 1 bubble. So that layer on its own, as you can see, is beginning to form over here, and it will soon pop up as you see over there. So you've got this nice type 1 bubble, doesn't extend all the way to the periphery. There's always that zone. It goes about 8.5 millimeters, maximum 9, and we did it in the absence of the Descemet's membrane. Then the question came is, why doesn't it go all the way to the periphery? Can I push more air and push it more and more to the periphery? And that's what we're doing here. Notice the 2 points of leakage at the periphery, and these, whenever we do this operation in the human eye, we see tiny bubbles come in the anterior chamber quite often. So we believe it was from the trabecular meshwork, that's what was written. But here you see at a pressure of about 700 millimeters of mercury, this bubble pops. It doesn't go all the way, but it bursts. So 700 millimeters of mercury, pretty high pressure it can sustain. So again, peel off the Descemet's membrane, and you will see for yourself now how this layer looks. Very resilient, very flexible, very pliable, but pretty tough. So that's this layer there at the back of the cornea. And you can see when I tug on it, I can see the striae extending all the way to the periphery. So it does extend all the way across, but the air can only cleave it for that 8.5 or 9 millimeters, no more than that. So that's the layer. The next question was, is this a random separation of the stroma? So what if we create this bubble, take away the Descemet's, and cut it out? So once we cut it out, can I inject more air and create another bubble and another bubble and so on? So here you see I've cut it out, and I'm trying to actually physically peel it off, and it's not possible. So we put some water and inject more air, and what you'll see is that there's multiple leakage points of air, but you will never be able to create another type 1 bubble after you've cut this off. So for us at that point we said, oh well, this is good. We know that it's not a random separation of stroma. Then in one of our meetings with our team, we said, let's challenge whatever we're saying. It's going to go out, and the critics are going to be there. So one criticism could be that when you inject air, you've already created the channels. If you've already created the channels and then you take this layer off, then air is bound to escape through the same channels without an opportunity to lift another layer off. So we designed another experiment which took me to Pescara in Italy, and there what we did was the following. We took this human eye, sclerocoin, we had 9 eyes with controls, peeled off the entire Descemet's membrane, and then we inverted the eye on an artificial anterior chamber, and then phototherapeutic keratectomy of the posterior 22 microns of the stroma. Because by our calculation, and I'll show you, that is the maximum thickness this layer could have in an old patient. So we take away the Descemet's, we invert the eye, the cornea, we mount it on an anterior chamber, and then we inflate it with BSS to make it firm, do central PTK, 6 millimeters optical zone, And now we've not injected any air, but we've taken away this layer. And then you come back and inject air. So if it's a random separation, you should get a bubble. And you don't. You see multiple leakage points of air. So this layer is unique. Once you've got rid of it, you cannot create a bubble. And you see those multiple leakage points from the deep stroma. So that's telling us that it's not a random separation of the deep stroma. And here's the image that became quite popular on the net and in the press, because we released the bubbles of air in the cornea, and that's the layer from which the descemet membrane has been removed. And this is the histology of that eye where we did PTK. So you can see the tissue here, which is outside the PTK zone, here inside the PTK zone, and you see all the bubbles come here, and they open up and they leak, whereas that layer, which is the attached part, which was outside the PTK zone, it was still there. So when the layer is there, and if you ablate it, no more bubble comes. Then we looked at the tissue in various different ways. If you look at the light microscopy, that's the layer, that's the descemet membrane. But very interestingly, we found there are strands of collagen extending from the deep stroma to this layer, and it cleaves along the last row of keratocytes, so that this layer is acellular. And these are the strands that we were seeing when we did the operation and had to cut or tease off. When we did the operation from the top and the bubble didn't go all the way, these were the strands that we were encountering. So this was the attachment of the layer to the stroma, not of the layer to the descemet. And here's that layer. It's made up of anything from 5 to 8 very compact lamellae of collagen. Here's the descemet membrane, here's the endothelium. And it has fibers which are oblique, but mostly transverse and longitudinal. But at the far posterior surface of the layer, very close to the descemet membrane, you see these dark lines. And these dark lines are here, and they are characteristic of long spacing collagen, which is present pretty much predominantly in this layer, in the posterior aspect of this layer, not so much or hardly any other part of the corneal stroma. We did some morphometry of the fiber thickness. We looked at the cornea anterior to this, and we found that the fibrils anterior to the layer were larger and statistically significantly larger, and the distance between the fibers was the same, because the way we measure the distance is from the center of one to the center of the other. That's what the software does. But if a fiber is smaller, then the distance, even though it's the same, there is more space here for the proteoaminoglycans than here. And if you have this gel of proteoaminoglycans in smaller fibers acting as the scaffold or the mesh, you would see why the gel makes it more impervious to air than would be the coarse fibers, through which there are bigger holes in between fibers. Now, interestingly, there's a paper in 1978 from John Marshall's group, and what he was doing then was he and his colleagues were looking at the origin of the descemet membrane and what happens to it over age. And here's a 20-week-old fetus, and you can see there's hardly any descemet membrane there. Then as the child gets older, a 5-day-old child, you can see descemet membrane. By 27 years, there's a fairly thick bit of it. And here in an 87-year-old male, there's a lot of descemet membrane. So his whole paper was on this and many other aspects of the microanatomy of the cornea. But what he didn't notice was, immediately above the descemet membrane, there's a clear zone between the last row of keratocytes and the descemet. And that zone increases with age and goes up to a maximum of about 20 microns. So that's why we chose 22 microns based on this paper for our ablation, although our own studies showed that the layer is about 10 plus minus 3 microns. So the range was from about 5 microns to 17 microns was the thickness of this layer. And even if it was 5, it was still made up of about at least 5 lamellae of collagen tissue. So, and if you go back and look in any histology text and electron microscopic pictures, you will see that this clear zone, this lucid interval between the last row of keratocytes and the descemet membrane is always there, but has never been commented on. We've never seen a keratocyte sitting on descemet membrane on its anterior surface. And then there is still an argument about this being its acellularity, because people say, oh, here's my electron, I can see a keratocyte within 5 microns. Now, quite apart from the processing and handling and swollen corneas, etc., we said, how many samples have you looked to find one keratocyte within 5 microns? But let's not mess about by doing sections, because they are 0.2 to 0.5 micron sections. Let's take a whole bit of the layer. So we took 6 millimeter triphenol, stained the whole thickness in whole mounts, and here is one image, and all you can see is only in the strands can you sometimes see keratocytes, those strands that have broken, because when a strand breaks, the broken end can be either with the stroma above it or with the stroma or the layer below it, and that might have a keratocyte. And the positive control was built in because it's a piece of desmis, and you can see a lot of endothelial cells that have remained on the desmis, which are staining, but there is no nuclei within the stroma. There are no nuclei there. And if you look at the posterior stroma of the cornea, different studies using confocal microscopy have worked out that we have 20,000 cells per cubic millimeter of the posterior stroma, immediately anterior to this layer. And if you go back and look at this, and even if you count these keratocytes, you have no more than 70 cells per cubic centimeter, and that was millimeter. So huge, almost as good as there are no keratocytes, and I would still put my hand up and say, we believe, and we've got evidence that there are no keratocytes in the layer. Electron microscopy, here's a scanning image. You can see that layer, the posterior surface, sorry, the anterior surface of the layer, which adjoins the desmis membrane, and that's the layer we're talking about. That's the edge with the desmis peeled off. And on scanning again, here's the layer slightly rolled on itself. So that's the anterior surface of the layer, the posterior surface, which attaches to the desmis, here the endothelial cells. The deep stroma has these multiple leaking points from which air leak. And here's the wall of a bubble, as you can see, with the desmis being removed. And you can see those strands, some of which are broken. And that's the layer in very high magnification with the posterior stroma and the edge of the bubble of air. And here's it in its entirety in a scanning EM. You see the layer, and you see how it does continue beyond. That's the desmis that's been cut off. The layer goes all the way to the periphery, but this part is very firmly attached. And that's fascinating because we know that the cornea is prolate in shape, and that peripheral part which is flat, that's the part corresponding to this part where this layer is firmly attached and it doesn't separate. Immunohistology, just to show a lot of type 1 collagen in the layer, but exclusively more type 6 collagen in the layer than in the rest of the stroma. And the long spacing collagen that we see on transmission electron micrographs is what is made up of collagen 6. So hence a lot of collagen 6. And we did a lot of other immunohistology markers, but none of them showed any different change. So we put this whole story together and we sent it to ophthalmology. They never take, ophthalmology doesn't take basic science, but we sent them an abstract. They looked at it and the letter from the editor was, it is basic science, but it is very relevant. We're happy to look at it, send us your full paper. The conclusions, however, are too grand. We'll see what the referees say. But anyway, cutting long story short, the referees accepted it and it was published. But at that time, then this was, as you can see, in May, and by June, there was all over the net, it was all over everywhere, and a lot of interesting sidelines emerged. And one of them was, you know, a great discovery, but what is he wearing on his head? Give me a break, this is the 20th century. And somebody said, well, you're ignorant, you're showing your ignorance, he's a Sikh, and Sikhs wear turban. And the whole discussion went along Sikhism and race and religion. And the next day, my daughter, Aarti, who's in Cardiff now, came and said, Daddy, you must read this one, you must read this. I said, and there it said, somebody had posted the comment, what did Jesus say to Harminder Dua? And the answer was, seek and thou shalt find. And then somebody said, it's not what on his head that matters, it's what in his head that matters, and so on. I mean, it was people having fun. But it became the most downloaded paper in the 3 months since publication, and the 11th most downloaded for all of medicine and dentistry. It got mentioned in the F100 Prime recommended articles, which is a very elite group of faculty who review all the papers and include some select articles. And at the end of the first year, it was number 12th of all ophthalmology downloads, the first 11 being Lucentis, surprise, surprise. Then there were also criticisms. There were also comments which said, wait a minute, if this is a true layer, it should also be present in children, and you've only shown it in an average age of 77. And I was in this place in Trivandrum in India. This young doctor, Vinay Pillai, came to me and said, this is what has happened to my patient. I did the perfect DALK, everything went fine, but the cornea is not clearing up at all. And when I look on the slit lamp, there is this. So double anterior chamber. So we did an OCT, and this is what the OCT shows. So here's the layer, and there is the curled, broken Descemet's membrane. So I said, you got a mixed bubble, and the inner bubble burst. And that's why your cornea is not going to clear. So suddenly, the understanding of the whole procedure became clear. You got to do a penetrating graft. So you did a penetrating graft, and in the graft, we could see the layer quite clearly over there with the Descemet and the endothelium. And this was in a 9-year-old child. So we said, well, okay, 9-year-old child has got this layer. And since then, we have shown it in a 3-week-old baby, in 3 eyes from 1-year-old donors, and in 1 eye from 4-year-old. So it is present in children. And that first criticism was answered, and that is a paper we are in preparation. And these are some examples to show the layer separating with the bubble with the Descemet and endothelium. But then came this application. If you inject air and create a nice type 1 bubble, you can put your needle in the bubble and suck out all the air. You can then trephine this tissue, which is made up of endothelium, Descemet's membrane, and the layer, and use it for endothelial transplant. And it is much, much better to handle and insert and unfold than just pure Descemet's membrane. You can see it doesn't roll as much, and it is very easy to unfold. And I was in Rwanda where I gave this talk, or the earlier version of it, and there was a gentleman in the audience, Mr. Agarwal from Chennai in India. He said, I want to do this operation. And why haven't you done it in humans? I said, well, our ethics takes a long time to approve of it. He went back, and within a day he got his ethics approval, and he did it in 6 children. And it was absolutely amazing. The outcome of this operation, not only did it show us that it can be done, but that he even used a 1-year-old donor to do the operation. So you can imagine 50 years is the cutoff to do DMEC in an adult because the Descemet tear. And what you want is young donors because they have a greater number of endothelial cells when you're doing a transplant of endothelium. And here it is, you can take a 1-year-old child, blow the bubble, you get this nicely, cut it out or refine it and put it back. So we published a paper jointly in the BJO. And here are examples of very bad bullous keratopathy. This is day 1 post-operative with the bubbles supporting the layer. And then you can see on OCT examination, the layer initially swells a bit and then it thins and goes down to about 28 microns. So this operation now, we've gone on about 2024. I did my first one in Nottingham about a month ago now, and she's doing extremely well. So it will pick up, and I stick my neck out and say it will replace DMEC in another 3 or 4 years because so many people will be able to do this. When we started off with Descemet stripping endothelial keratoplasty, we transplant at least 150 to 200 microns of deep stroma with it. So it's pretty thick, so the whole cornea thickness increases. It's relatively easy to do, so the conversion rate from penetrating keratoplasty to DSEC was very high. Straight away, within 2 or 3 years, about 80% people had converted to doing DSEC. But when DMEC came, where you only peel off the Descemet to try and transfer that, the uptake hasn't been as much. It's only 20% of surgeons have converted because it's technically so challenging. This operation will be much easier to do, and with the little instruments, we can guarantee you get a bubble each time, and hopefully it will be much higher than 20% the uptake. Then, for me, the most rewarding part was what was happening around the world. And this gentleman from Cairo wrote to me saying, I was doing a cataract operation, doing a DALK operation in a patient with a very dense scar due to infective keratitis. And I took off the top, and there was this layer, and the layer was transparent, and through that I could see a dense cataract. So the first thing it told me, why should this layer be transparent when the rest of the cornea has gone opaque due to infective keratitis? Because there are no keratocytes which convert to fibroblasts and myofibroblasts and lay down scar tissue. So that could be a clinical corroboration of what we are seeing. Secondly, he said, I didn't want to put a new cornea and send this patient away, and he'll say, you took all my money and I still can't see. So he did the whole cataract operation under 10 microns of tissue with the bursting pressure of 700, so that's why he could do it. And he's now done about 4 of these operations, tried one under a Descemet's membrane with a type 2 bubble, which promptly burst as soon as you put the viscoelastic. So we recommend strongly don't ever try that. But this paper is also now published in the journal Eye and is online. So we call it the dark triple. So you can do a whole cataract operation, even a vitrectomy if you get posterior capsule tear, and put a lens in the eye under this layer. In macular dystrophy, again, we see very few of these patients, but from across the world, I've got videos and samples of tissue where in macular dystrophy, the layer is affected with these opacities, little areas of opacification. And most of us now know that macular dystrophy is predominantly an endothelial dystrophy. So we are postulating that the characteristics of this layer are related to the influence of the endothelium on that layer. And that's why when there's an endothelial problem, this layer is more likely to be affected as in macular dystrophy. Always surgeons thought that they make a trephine of 8.5, they inject the air and they stop when it reaches the bubble. Actually, they don't stop, the bubble stops. So the recommendation is never try a 9 millimeter DALC, because your bubble will not go that far. You will have to tease out the strands, you can tear it. So leave it alone or go 7.5 or 8.5 at the most. But what happens if there's a patient with trauma to the cornea? And this is an extrapolation from the next video. Now here's a patient that comes to us, a sclerocorneal disc, who's had a previous cataract operation. Now notice as the eye fills with air, the cataract wound opens up, the side port opens up, and as more air injected, not only is it leaking from the periphery, but it's also leaking from here. So this layer, like the Descemet's, never heals. You will still get a bubble, but it will never be as big as you want. So if you have a penetrating injury anywhere, cataract wounds are relatively peripheral, but if there's a central or a more paracentral incision, you'll get a very small, so you don't have to use air to separate this. So that's a very important, useful piece of information we've got. A couple of more clinical videos here. Now this is a patient where a nice DALC operation has been done and is in the process. The Descemet's has been exposed, and we're trimming the edges. And what happens over here, you will see in a second, as this particular edge is being trimmed, the whole Descemet's bursts. Now, with hindsight, we know this patient had the type 2 bubble. This will never happen with a type 1 bubble. So you can tell, I cannot guarantee which bubble you're going to get, other than 80-20 is going to be the 80% time the right kind. But if you get a type 2 bubble, I tell all my colleagues, be very careful because it will burst on you. And here's one example, and this is another example where the doctor has actually done the operation, is put the new cornea on the eye without the Descemet's, taken it off, and for some reason he holds the eye and moves it to one side. Now don't blink, because it happens, happens very fast. So what you'll see here is that when he does that, the eye pops. Now, this will never happen with a type 1 bubble. It only happens with a type. We know now we can make the operation a lot safer, not to do these kinds of things when you've got a type 2 bubble. Everybody recognizes that, and we can still have a nice DALC operation without, even with a type 2 bubble. And we've got some anecdotal evidence, it's not published yet and it's not confirmed, that acute hydrops in keratoconus, we've all seen that, and we all believe it's due to tear in the Descemet's. But how many times do we get traumatic and surgical tear in the Descemet's? We don't get acute hydrops. So in the background of an abnormal collagen, you need a dehiscence not only of the Descemet's but also this layer for that stroma to get completely hydrated. We've got some evidence to show that's happening in these patients. And similarly with descemetocele, we've always thought that a descemetocele resists perforation for a long time. And that's because some of them are covered with this layer. And it's only when this layer melts that the Descemet's then perforates. And we've shown that again with videos and with some histology. And then this what it's going to lead to, we don't know, but this was quite an interesting finding. Moving on rapidly, what you see here is the Descemet's ends here. That is this layer coming, and this layer fans out to become the trabecular meshwork. The trabecular meshwork does not end at the Descemet's membrane. In fact, just as the rest of the cornea continues as the sclera, this layer continues as the trabecular meshwork. So if my forearms were the layer, then my fingers are what happens to it at the end, and they form the collagen core of the trabecular meshwork. And we've shown that. Again, this is a paper that we've published, and all of these publications have come in the years since the original. And here you can see is the Descemet's membrane with the trabecular meshwork. The Descemet's membrane has been removed, and you can see this layer, and you can see how this layer is forming the beams of the trabecular meshwork, and they're a little more denser with fewer holes towards the Descemet, become larger, as you see over here. So that's very clearly shown in many other images. And now, to ask you a question, I have been telling you this layer is impervious to air, impervious to air. Then how does air get through it to form a type 2 bubble? Because, and also remember, the type 2 bubble always starts at the periphery. So these two things need to reconcile, and what we found is that there are these holes at the periphery. And if your Descemet's membrane is attached here, the air will leak into the anterior chamber, those tiny little bubbles you saw coming out from the periphery. But if the Descemet's is attached here, then air leaking from this will strip the Descemet's off at the periphery, move to the center, causing a type 2 bubble. So it has now clarified and added further insight into the microanatomy of the periphery of the cornea, where the existence of these holes and their relevance to the operation that we are doing. And here, as you can see, a Descemet's membrane. So what we did is we just when the bubbles started to form at the periphery, we stopped, we peeled off Descemet's and did scanning. And you can see right underneath that, there are these holes. And they're not in every patient, and they're not all over. They're random. So some of them will get this, not all. And in some places, we see this. It's quite interesting that instead of the trabecular meshwork forming around here, you see this sheet, which is not fenestrated. And you can see this sheet over here as well. So what it's telling us is that if this anomaly covers a larger area of the trabecular meshwork, then no aqueous is going to get through it. And that's where you have to slit the trabeculum to let the air, and you can get congenital glaucoma. So there may be some information coming through on how it's the failure of this layer to form the trabecular meshwork that causes glaucoma. So again, interesting things ahead. And this is a very complex slide, but just to show you, there's Descemet's membrane, but we have shown trabecular cells, this huge cell here, and this huge cell here, and this huge cell here, all underneath Descemet's membrane. So the definition of the end of the cornea is where Descemet's membrane ends. Within 0.5 millimeter of that centrally, you see trabecular cells. The keratocytes are way up there, as you see over here. So that's again new information related to the trabecular meshwork. We confirmed all that by immunohistology. And the final bit, last 2 or 3 slides, was because of my various talks, I was invited to give a talk at the European College of Veterinary Ophthalmologists. And I gave a talk over there, and they said, is it present in animals? And I said, I don't know. So one of them started collaborating, and we tried in pig eyes, we couldn't, but in horse eyes, it's amazing, the size of a tennis ball, we could create both the type 1 and the type 2 bubbles. So it is present in horse eyes, and on the 22nd of November, I'm going over to Cambridgeshire. We've got some dog eyes to try this on. So that's my last slide here. The effect of this layer on posterior corneal curvature and posterior corneal biomechanics is something we are investigating and is yet to be determined. What happens to the cornea? Every blink, every heartbeat, every eye rub, it transmits pressure from the cornea to the periphery. Is it going to the trabecular meshwork? What is it doing over there? Defining different animal species and their types of this layer. There are many other questions that are all coming forth. We've got very useful collaborations with Vienna, a very elaborate OCT examination of the layer with a very high resolution prototype OCT, and with Geneva and Sao Paulo, Cardiff, and many others. So watch the space as the story unfolds. Thank you very much for your attention.
Professor Jewell will now take questions. Does anyone have any questions?
No. Did anybody have any questions? Susie, did you have a question?
Well, I think you almost answered it. It was the implications of glaucoma with the dual layer. And I think it's to do with childhood glaucoma more than adult glaucoma. But does it have any implications for adult glaucoma with the trabecular meshwork?
I honestly can't answer that question completely, but what is fascinating me now is why is it so firmly attached along that peripheral 1 or 2 millimeters? Because had that not been attached, any stress, imagine if this layer rips off all the way to the periphery, it will rip off the meshwork as well. And perhaps that's the buffer zone which stops the stresses and strains of the cornea reaching all the way to the trabecular meshwork. So the implications are that it's there, and it could have been worse had it not been for the buffer zone, but it's not. So, but the fact that it does form the collagen core of the trabecular meshwork, which has a lot of collagen 6, and so does this layer. And this layer thickens with age, and the collagen core would also thicken with age, and hence the narrowing, and it all sort of seems to add up quite nicely.
So that's how the trabecular meshwork narrows with age?
Yes.
Oh, interesting. Any further questions?
Do you think that it's not only the stroma that thins during keratoconus and all these other layers thin symmetrically?
The most certainly do, because everything thins, but how much this layer thins we don't know. My guess at the moment is that it thins relatively more than the rest, and that's why it also splits. And when it splits, that's when you get, like I said, the acute eye drops. But it wouldn't happen. So we tried an experiment. We just split it and put it under and raise the pressure of fluid to see if we don't get it. So there has to be the split of the layer in the context of an abnormal collagen, as you've rightly said. So it's something going on in keratoconus in all the layers, which then requires this tear to just precipitate the acute eye drops.
I just had one question in regards to the layer being so thin. What gives it its strength?
It is because if you look at the more posterior stroma, the number of collagen layers are about, for the same, millimeters for millimeters, they're about 3 to 5. Here it is 5 to 8, so they're very much more compact. And I think what gives it its true strength is there are no keratocytes. And you might argue, why would that be so? So just ask yourself the question, how does air get through the whole cornea with all these little bubbles? And the answer is, if you look carefully, in the wall of each bubble is a keratocyte. So the keratocyte spaces, which are connected with each other, as we know, all of them communicate through the processes, allows the air to move through the stroma. But when it reaches here, there is no space for it to go because there are no keratocytes in it. And that's what then the compactness plus the fact that there are no cells to separate it gives it its strength.
Can you tell us if you feel there's going to be any significance in how we think about oxygen transmissions or the performance of contact lenses with your discovery? Does that make any difference to how we think about contact lenses, how they work on the eye, what problems we might have with contact lenses?
I don't think it'll make any difference to what we're already doing, because we've already been doing everything we're doing with no problems. It is the posterior corneal curvature, so more to refractive surgery rather than contact lens fitting and the implications of contact or the consequences of contact lens wear. So what role it plays in posterior corneal biomechanics will be very interesting to see. So for example, if you have a bow with a string and it keeps the bow in shape, and that's what this is doing. So you have this layer which is firmly attached and is keeping the shape of the cornea. So if this layer starts to undergo some kind of degradation preference to the rest of the stroma, then we might see changes in the shape like we see in keratoconus, and it goes all over the place. And again, in relevance to the glaucoma question, we know that, and it will partly answer your question as well, that when you do a penetrating graft, you go through and through this layer. And the incidence of glaucoma after penetrating keratoplasty is higher than can be explained by the use of steroids alone. So why should it be more? Because we are cutting this layer completely, and then with stitching, we know it never heals back. So has that got some role to play? Again, these are just questions. We have no answers at the moment.
One last one, if that's all right with you, Professor.
Sure, no problem.
Hi, Professor Dewar. I just wanted to ask, if you're saying this layer is not very permeable, how does that affect the endothelial pump?
It's impervious to air.
Okay.
Okay, it's very, very permeable to water. The fluid exchange across it is not an issue.
It gives me great pleasure to award this trophy to Professor Dewar for the 11th Pioneers Lecture on the novel pre-Decimus layer, the Dewar layer.
Thank you very much.
So I'd like to say a great big thank you to all our sponsors, Alcon, Bausch & Lomb, David Thomas, Cooper Vision, Johnson & Johnson, Scope and Topcon, because without them this day wouldn't be possible. And I also would like you all to just do one thing on your smartphones or on your laptops, sorry, on your iPads, and that is to download the new app. And if you go to the App Store, it's British Contact Lens Association. And I'd also like to wish you all a safe journey home, and thank you for coming. And you need to hand in these CET forms on the way out, or you won't get any CET points.
Thank you. Safe journeys home.